Welcome to Last Slide Dentistry. Today we are covering another oral patho topic, and that is Ameloblastic Fibroma. First, I will start with an introductory, scenario. Like imagine a 14-year-old patient comes in with a delayed eruption of a molar. The X-ray shows a radiolucency around it. What could it be? So today we are going to discuss ameloblastic fibroma, a rare but important odontogenic tumor you must know for exams and your clinical practice. I have given some key points like it's a circumscribed odontogenic tumor common in young patient, as I have told, 14-year-old patient, okay, and often associated with unerupted molars. Now, coming with the definition, ameloblastic fibroma is a true biphasic odontogenic tumor. That means both components, the epithelial part and the mesenchymal part, are neoplastic. Histologically, it resembles the cap and bell stages of the tooth development. It is very important line. In simple words, it looks like early tooth formation frozen in time. Okay. Earlier, some believed it was just an immature odontoma, but that theory has largely been disagreed or rejected. Now, coming on the epidemiology, this tumor mostly affects young patients with an average age around 14 years. It can occasionally appear in adults up to 40, but that's really uncommon. The most common location, sorry for that, the mandibular molar region, especially near unerupted molars. So, young age plus impacted molar should raise suspicion for this tumor. Now, coming on to the clinical features which you can face in your clinics. Clinically, it's slowly growing and often painless. Many times it discovered during investigation of a delayed eruption. If it's close to the surface, you may see slight buccal or lingual cortical expansion, but usually there are no dramatic symptoms, and that's why it can be missed. Now, coming on to the radiographic features. Radiographically, the lesion appears over an unerupted tooth. It can be unilocular or multilocular. The borders are usually well corticated, meaning clearly defined. Size can vary from small incidental findings to larger expanded lesions. So, radiographic features, as I have told, it can be either a unilocular or multilocular. Coming onto the histopath epithelial component. So, under the microscope, you will see thin strands and cords of odontogenic epithelium. These resemble the dental lamina in early stages of tooth development. It is very important. This developmental appearance is a key identifying feature. Now, coming on to the histopath, mesenchymal component. The background consists of embryonic connective tissue with widely spaced fibroblasts. You may also see zones of hyalinization, occasional focal calcification. The presence of both epithelial and mesenchymal neoplastic components confirms its biphasic nature. That is the reason I have used the word biphasic in the start. Now, on to the next slide, differential diagnosis. Now, here's where exams try to trick you. It can resemble odontoma or other odontogenic tumors, but odontoma contains mature dental tissues, enamel, and dentine. Ameloblastic fibroma does not. Histology is the key to differentiation. Coming on to the treatment of this tumor is treatment is surgical enucleation. The lesion is well encapsulated and usually separates easily from the surrounding bone. However, and this is important, recurrence is relatively high for a benign tumor. Why? The reason is because these lesions are often multilobular. If you leave even a small portion behind, it can reoccur. Now, the key points, the final clinical takeaways you should consider. So, just let's summarize it. As I have told earlier, that a young patient or mandibular molar region associated with unerupted tooth, well defined radiolucency by phasic histology. That combination should make you think ameloblastomic fibroma. So basically, we got some clinical scenarios ahead that shows that how to differentiate where ameloblastomic fibroma is given. So, a 13-year-old boy, okay, a young patient, comes to your clinic with a slowly enlarging painless swelling in the mandibular molar region, the location. Radiographic shows a well corticated unilocular radiolucency over an unerupted molar. Okay, are you getting these key points? What is the most likely diagnosis? So, the first option is odontoma, second is ameloblastic fibromas, C is dentition cyst, and the last is amelofibroma. So the explanation I want to give is why ameloblastic fibroma, because it occurs in young patients, average 14 years. Commonly associated with unerupted molars, okay, slowly growing, painless, well corticated radiolucency. We can see here odontoma usually present differently in histology and more calcified. Now we got another scenario here. A panoramic X-ray shows a multilocular radiolucency in the mandibular molar area of a 14-year-old girl. The lesion surrounds on unerupted tooth but has well-defined borders, which features a most ameloblastic fibroma over an odontoma. So the option is C, histologic biphasic nature. So biphasic means epithelial plus mesenchymal pattern is key diagnostic feature. Odontoma is more calcified and has fully formed dental tissues. It doesn't have fully formed dental tissues. Age and location are similar, so histology is crucial. So that was all from today. I hope you have enjoyed our video and it was quite helpful for you. And in the next coming videos I will keep making more videos about oral path, tumor lesions, etc. But I want you guys to just comment and ask for the topics you want to learn, and it also please subscribe my videos and like them, as it helps me and keep me motivated in